Ladies and gentlemen, this session, Can Detroit Transform America's Health? The context is decisive, is hosted by Wayne State University. Please welcome the Vice President of Health Affairs for Wayne State University, David Hefner.
Hey, thank you. Thank you very much. Very kind introduction, and I welcome you to our kickoff initiative here that we'd like to announce. We've also titled it A Vision for Healthy Detroit, and as you can see, channeling the power of community, which is key. We wanted to start, though, with a different definition or a more expanded definition of health. So rather than thinking about this simply as health care, this is health in the broader description of the World Health Organization, as is a state of complete physical and mental and social well-being. So if we use that for a framework of health as we're speaking about it, and can Detroit transform healthcare not only for itself and the nation, let's elevate the conversation to that higher stature, because we want to radically improve, not just incrementally improve, health outcomes in Detroit. So I'm going to walk through some of the complexities and hopefully do it in a simplified manner and do it in a very quick step way so that we can have our panelists come up and actually field some of the questions that you and I may have. And I think everybody's familiar with the staging of this, that we have fragmented healthcare and we're moving it and have an interest in it being highly integrated. Lagging outcomes have historically been embedded in our healthcare system. We want to move to transformational outcomes. It's very expensive. We need to get much more value, have it be much more effective. Individual healthcare, and now think about not just individuals, moving it to population. Episodic healthcare to preventative, and then lastly, disparities, which we want to convert to equity. So if we use that again as a current state, always useful to know where we are on the broader scale as well as a starting point. And this is just a depiction. If you can see, the way to read this chart is all the organized and developed countries moving up to the top have much better value, half the cost for a longer life expectancy, and then where the outlier is the U.S. to the right, where we pay much more for health care and yet have a lot lower longevity. And you can see we're 42nd in the world, not a good place to be. And when you compare that to Detroit, the gap is even much broader than it is in the world, which, depending on which zip code you live in, there's a 13-year difference in Detroit. That's something that we have to deal with, take care of, and close the gap of. Then this is a framing device for those of you who don't live healthcare every day, but we thought it would be useful to speak from. We've highlighted in the center, usually when people speak about health, they're talking about healthcare, and that's in that block called clinical care, usually around hospitals, doctors, nurses, individualized patient care. But as you can see in those blue boxes, above and below clinical care, a greater percentage of what impacts our health is outside the box of clinical care. So when we're rethinking how do we have Detroit reposition itself, we really are intent on using this device to say we have to get broader and work with more constituents, and at the same time not boil the ocean. So here's an example. If we just pulled out the diet aspect under health behaviors, many great organizations are making a difference in this sector in their unique ways. But the question at the bottom is the one that we're posing to ourselves, which is, to what degree are these organizations working together, both with themselves in that sector and then across with the existing health infrastructure represented in all those other boxes? And one more example related to that is if we looked in the housing side, again, great organizations that are committed to making a difference with regards to housing and different approaches in that. But again, to what degree are they working together and across with different players that are out to also make a difference? And then we also have to think about the cost side. So now we do have a window into that when we think about it from a healthcare perspective, this is some of the data, again, that I think you're familiar with. The yellow boxes are those which have multiple conditions called comorbidities. But if you have multiple conditions, the cost of taking care of you at the individual level, when you extrapolate it, is very expensive relative to those other colors, which is less conditions. And many of us may think, you know, Medicare or Medicaid is a social policy, legislator, or taxpayer issue. That's not my thing, particularly in the business world. Yet the data in the business world looks much the same and mirrors what we're seeing in the public sector. So we all have a problem. We all have to get it right. We all have a stake in dealing with this. And fundamentally, we need to keep ourselves well at the individual and population level such that we have less conditions. Drive those costs down, have us be healthier, and thrive. Now, we've been posing a question that as we kick off this initiative, which you'll hear is a long-term initiative, we would want to start with cardiovascular disease versus neurologic diseases or cancer or other things that ail us as a population. But certainly here you can see it makes the case that cardiovascular disease outpaces everything else in the nation and in Detroit. It is what kills us, essentially, and we need to be dealing with that in a different way. Cardiovascular disease also, though, just from a practical point of view, you can make interventions with your cardiovascular health, again, at the individual level and the population level, and measure it in very short time increments relative to all the other conditions or diseases that you would want to impact. So we're using cardiovascular disease as a tip of the spear to be able to say, can we impact health and measure it over time and use cardiovascular disease as part of that. We have the American Heart Association who will be on the panel with us as partners in this effort. One of the things that they did, which was brilliant, is they even rethought how do we fund our research endeavors, and instead of, much like spreading peanut butter across a very broad base, they said we have to cause a biomedical breakthrough with regards to what our goals are in delivering a better health in cardiovascular disease. And they said, let's invent this. 3 years ago, one brave idea was given birth to, and essentially what that was taking a big piece of their funding stream and dedicating it to one research team in a competitive process. So they put in $25 million, which in the research world, if you got that as an investigator, that buys you freedom time to really pursue that kind of a breakthrough. And by the way, what happened with that is Google Life, now called Verily, came forward, said, great idea, we're going to match your 25, and they put 25 in. And then AstraZeneca at the same time said, great idea, we're going to put 25 in. And so now you had a $75 million pool, and in a competition of all these 300 plus scientific teams across the world came together, and it was awarded to one research team out of Boston for a $75 million kitty. Now that is designed to cause a breakthrough at the biomedical or individual level. What we're proposing here is how do we take that kind of a moonshot and apply it to populations? How do we have a one brave idea approach where we can bring not only ourselves together, but also other agencies, Robert Wood Johnson, and other foundations that are interested in making an impact, but do it in concert and be able to do it at scale. And we fundamentally believe that creating a breakthrough is embedded in working together, not apart. So you can hear that threaded throughout our comments. And if you said, well, who's going to lead that? In the center, you can see it's the community leaders and members that have to make that happen. But it is with bringing all the other different community groups together and working in concert. So that includes you and your chairs, hopefully, us. We have to rethink ourselves as a university to approach something like this. And we are fundamentally inviting you to be part of this endeavor. Now, why Detroit also may be a question that we wanted to answer in advance. And why Detroit? is much like we learned when we were younger, because we're Goldilocks, and we just know that we're not too big and we're not too small, and we're just right. We're just right in population, we're just right in the way that we can get ourselves aligned and work together. So from the local level to the state level, we believe we can bring the constituent groups together to work in a whole new way. Why not us, right? Now, this context, this new context, does require a rigorous approach. Rather than fire, ready, aim, we're intent on actually getting our arms around all the different endeavors that are occurring out there already. So the first point is, let's do it with discipline and do it in a way that demands accountability of ourselves, and we expect to be held accountable. We want to harness these key points of leverage that exist that people and organizations are already doing in such a way that we can bring those together to cause a transformation in Detroit's health. We want to do this in an applied research framework, so we have that kind of rigor where it's measurable. And we want to be able to take it in a way, particularly with the American Heart Association, in a way that we can scale it and have it be replicatable so that in other urban areas, Houston, LA, across the nation, we can create this model and be able to nucleate it in other situations. But it's a context of 20 years. It's not a 1 year and move on. This is really inside the kind of thinking that requires us to act and operate in a 20-year time frame, knowing that we're bending a curve in a very complex area of life. And it's going to require us all being in an entrepreneurial mindset and investment mode, because the ROI for this is downstream. It's not immediate. So please do hold us accountable. We intend to be back here every year for the next 20 years, same time, same place, and we will report out our progress. And with that, the Reverend Martin Luther King said, "Of all forms of inequality, injustice in healthcare is the most shocking and inhumane." So to that end, on your table, we are extending an invitation to you to join us and be brave together. So please do take that, talk to any of us or call us, and we will obviously be there. We want your participation needed at the table. Thank you very much.
Please welcome Vice President of Field Health for the American Heart Association, Jessica Donzie Black. Director and Health Official for the City of Detroit Health Department, Joneigh Khaldun. President of Wayne State University, M. Roy Wilson. Senior Vice President of Community Health and Equity and Chief Wellness and Diversity Officer for Henry Ford Health System, Kimberly Dawn Wisdom. And to moderate the discussion, Chief Executive Officer for the Michigan Primary Care Association, Loretta Bush.
Well, good morning. David started us off with a great foundation. He talked about this concept of radically improving the health outcomes in Detroit. And to do that, we would need to elevate the conversation. And so I am confident that that is what the four of you are going to help us do today. And with that, Dr. Calhoun, I'd like to start with you. You know, you bring a unique perspective to your role as the City of Detroit's health director. You're a practicing ER doc in the city, but also you've had over a decade of experience implementing population health and community health programs across the country. So from that perspective, please give us your vision for public health in the city of Detroit. And as you answer, think both about the challenges as well as the opportunities there in Detroit.
Absolutely. Thank you. Thank you for the introduction, and thank you for having me on this panel today. So when I think about public health in Detroit, I really think about the public health ecosystem. And what that really means is you have to think about businesses, schools, emergency medical services, hospitals, all of the agencies, if you will, that really can have an impact on the public health of a city. So my vision for public health in Detroit is really that we are all working together, this public health ecosystem, leveraging data, leveraging resources so that we can really create the conditions so that everyone in Detroit can be healthy and thriving. So yes, I have spent some time on the East Coast. I just came back a couple years ago home, but before that I spent about 17 years up and down the East Coast. And one of those roles I had was as Chief Medical Officer of the Baltimore City Health Department. And one thing, many of you know, Baltimore and Detroit have a lot of similarities, right? Similar population size, a lot of issues with disparities, challenges with access to care. But one thing I was able to witness there is what I call public health magic. And so what do I mean by that? They were able to strategically, over the course of a few years actually, decrease their infant mortality rate by about 40%. And they started where Detroit's infant mortality rate is right now. They were able to decrease their number of safe sleep related deaths by 50% over the same amount of time. And we were able to decrease the teen pregnancy rate by about a third. Okay, so that's public health magic as far as I'm concerned. Absolutely. And so how do we really do that in Baltimore? We really focused on three things, and what we're really talking about here with this new initiative, right? They were able to align projects and programs. So instead of everyone kind of focusing on getting their own grants and trying to win and trying to do their own program, focusing probably all of them on the same population of people, they were able to align around similar goals and metrics, right? They were also able to use data and able to target, right, and scale those programs they were effective. What it also meant was, sometimes programs aren't effective and they need to be I need to share that, and then we don't target and scale those programs, right?
Absolutely.
And then finally, they were also able to really hold folks accountable with data and metrics and tracking, and that's how they were able to really improve those metrics in Baltimore. I also wanted to share just one thing, an example of what we're working on at the Detroit Health Department that I think is really getting to this point of aligning and bringing folks together. Teen pregnancy in Detroit is a challenge, right? A teen in Detroit is 2.5 times as likely to get pregnant as a teen across the rest of the state. So what we did, we brought together, using Medicaid data actually, brought together every provider of long-acting reversible contraception in the city. We know where they are, we know who they are. We actually brought them all to the table and said, hey, what services specifically are you providing? What are some of your barriers? What are your hours? How can we all work together so that we can actually improve access to contraceptive care for our young people in the city? So they've all come to the table. We actually have a map of where they all are. We actually, in a few weeks when we officially launch, there'll be one number that any person in the city of Detroit can call. We'll be able to help you get to one of those providers and our own teen pregnancy clinic that was placed specifically where we know there's a need and not a resource. We'll also be able to, getting to those social determinants of health, be able to provide transportation to such a clinic if you want to go to one. And we've got all these providers actually sharing their data and their metrics, so we'll be able to know, is this working? Maybe there's a challenge there. Can we help get more people to your particular service? So that's just an example of what I mean by aligning and working together, and I look forward to working with my partners here on the stage as we do this work.
Well, thank you, Dr. Calhoun. As you were speaking, the thread that kind of went throughout was this whole collaborative and bringing partners together. And there's a quote that says, many hands make the work lighter, right? And I think also more successful. We get to that public health magic. So Ms. Black, next question is for you. So David spoke briefly about the American Heart Association, the One Brave idea. So what elements of that approach would be critical as we think about applying it to population and community-based health in underserved communities?
Yeah, so when you look at sort of the analogy between that biomedical approach and then what we're talking about in population health, I think one of the things that really stands out is that opportunity and that need to be aspirational. So when One Brave idea was conceived, the goal wasn't to reduce heart disease, it was to eliminate heart disease, right? And that's the view that they went into that project with, and that's the expectation of the outcome of that work. And I think similarly, when we look at the city of Detroit and Wayne County, in the most recent Robert Wood Johnson Foundation's county health rankings, they look at various health factors across counties and then set them up. Wayne County is 83 of 83 ranked counties in Michigan. There's tremendous need and opportunity to move up. Similarly, if anybody was in the mobility session yesterday, you may have heard reference to the fact that Detroit sort of fell off the list of potential sites for a new Army organization or a base, kind of a new conception that they're doing, because the livability score was not high enough. And so they were sort of outranked by the other communities. The livability score, the AARP livability score in Detroit is 47 out of 100. When you kind of dive into that more closely, the things that bring it down are the same things that affect the county health ranking. It's food security and food access, it's transportation, it's housing security, and it's healthcare. That healthcare score is 32 out of 100. Now that doesn't mean there aren't awesome things going on. There absolutely are, and there are people doing tremendously good work, and there's a lot of foundation support and public health support and hospital support and lots of hands. But I think there's certainly opportunity to lift that up. So going in with that sense of aspiration and saying, it's not about being a little bit better. How could you make Detroit one of the healthiest communities in the country? How could you go from perhaps how it's perceived today and how it is for many of the people living in Detroit to saying that's a place we would want to live, regardless of where we are in the socioeconomic spectrum? This is a place that has those supports that people need to be healthy, to thrive, to reach their full potential. So we have to have that aspiration element. The other piece is really analogous to what you've already heard, which is there has to be a collaborative approach. When we talk about, in the public health frame, we sometimes talk about this through the lens of collective impact. And some of the key elements of collective impact, number one, is that you have a genuinely common agenda. So sometimes we're all kind of working on similar things, but we each have our own goal, our own measurement, our own way of defining success. That's okay to some extent, but if we genuinely want to move from number 83 to number 1 potentially, we need to have some common elements where we all agree this is the goal, these are the metrics, and we will hold ourselves accountable to that. And the other piece of that is the concept of mutually reinforcing activities, meaning you play to the strengths of the different organizations. Each of us come to the table, regardless of whether we're in the business sector, the healthcare sector, the nonprofit sector, the public health sector, with things we can do and things we can't necessarily do. And it's important to be leveraging the strengths and also really leveraging the strengths of the community themselves. Absolutely. What do people want? What's important to them? What do they perceive as their assets? And how can we really lift that up into part of the solution? So that's the other piece of that genuine collaboration. And then I would say the last piece is that both patience and persistence, which is a tricky combination. They sound sort of opposing, but just as we wouldn't expect every biomedical experiment to actually work, right? We learn a lot more about what doesn't work than what does work. We need to recognize that as we go through this, to David's point, this work takes time. And if we expect there to be 6 months outcomes, otherwise we're out, we aren't going to see it. So we need to absolutely have, benchmark measurements to be able to say, are we moving in the right direction? If not, how do we redirect? How do we change our what we're doing in order to evaluate? Making sure that we're evaluating along the way and course correcting as needed, but also recognizing that ultimately this is a marathon. This isn't a sprint, it isn't a short-term thing, and we need to be in it for those long-term outcomes, otherwise we aren't going to achieve them.
Exciting and truly aspirational. When you start using words like elimination instead of small changes, but actual elimination, that is phenomenal, and that does start to elevate the conversation. Mm-hmm. So I'm going to turn to the audience for a moment. You have blue cards on your table, and we would ask that if you have questions, if you will write your questions on that card when you're finished speaking. The cards will come up, and there's someone right here to my right who is holding up. He will take your cards. All right, President Wilson. Wayne State University has been in Detroit now for 150 years, and you started off as a medical school, something that I wasn't aware of. With the amount of health disparities across the city today, what is Wayne State University's leadership role in improving health outcomes?
Well, the first thing I would say is that Detroit and Wayne State has some assets from which to build from. Let me just talk about a few. The NCI designated Comprehensive Cancer Center, for example. Every cancer center in this country wants to become a comprehensive cancer center, NCI designated, but there's only 64. In order to become an NCI designated comprehensive cancer center, you have to have a certain amount of research, you have to have a certain amount of clinical activity, it's a peer review mechanism, and only 64 are selected, and you have to continue to show that you're doing the work and to be reselected. The reason why there's one in Detroit is because of the kind of work that's going on in the Cancer Center, the Carmonas Cancer Center. For example, there's a large grant that we just got, which is the largest cohort of African Americans being followed for cancer. Cancer is one of those health disparities where African Americans nationally have higher morbidity and mortality than non-African Americans. And in Detroit, that disparity is even worse. And so to be able to take the information from this very large cohort of African Americans with cancer and try to apply it to what's going on around the country would be a huge service. Another example, in fact, even more exclusive, is the PRB, the Perinatal Research Branch of the NIH. There's only one clinical center outside of Bethesda, and that is the PRB in Detroit, Perinatal Research Branch. And the importance of that is, again, the reason why it's placed there in Detroit is because of the population in Detroit. Detroit suffers from a very high infant mortality rate, one of the highest perhaps the highest in the country, but worse than even some third world countries. And one of the factors for that is whether or not a mother can go to term. Mm-hmm. And not going to term is a big factor for infant mortality. And one of the programs that I just love, and it really shows the power of collaboration, I think, is a program that the mayor actually started with one of our PRB investigators, Sonia Hassan, Make Your Date, which is a program to try to get mothers, expectant mothers, to be able to make their date rather than deliver prematurely. And it's a collaboration between hospitals, DMC is involved, Henry Ford's involved, between insurance companies, between providers, transportation. You know, all of these different entities are involved to try to get these expectant mothers to make their date and thereby reduce infant mortality. I think that is, again, just a great example of how you can operationalize collaboration to the greater good. You know, in one of my previous lives, I was responsible for coordinating the health disparities strategic plan for trans NIH, for the entire NIH. And one of the things I learned from that is that there are so many different approaches that you have to use them all. You can't just go with one approach. Health disparities is a very complex interaction of behavior, of genetics, of biological, of environment, of health systems, of social determinants, as was mentioned. And all of these different kind of approaches has to be used. And so with that in mind, this initiative, I think, is going to be very important. And we're going to start with the planning phase, and Wayne State's going to commit $1 million to begin the planning phase for this long-term project. And I'm going to challenge all of the individual schools and colleges and institutes within our university to think about how they can participate through their own unique lens and through their perspectives on how they approach things to dealing with the issue of health disparities. And then just one other thing that I think I'll mention is that I think the other thing that could be very helpful is if there was a school of public health in Detroit. Mm-hmm. Again, in one of my previous lives, I started a school of public health in Colorado, and the unique aspect of that school of public health was that even though it was started by the University of Colorado at Denver and the Health Science Center, it was also in collaboration with Colorado State and University of Northern Colorado. So it was a statewide school of public health. And I'm mentioning that because I see Ora Peskovitz, the president of Oakland, sitting back there, who's a renowned physician in her own right. And we will welcome that kind of collaboration, Ora, to think about a wider casting a wider net and collaborating on developing the school of public health with DMC and Henry Ford and other universities. And I think that would be a huge asset for the city of Detroit and the surrounding area.
President Wilson, I really like the fact that you started from an asset base instead of what's lacking. All the way throughout, there was the threat of that. You ended with that as well. And I think that that's very important in this conversation. And I think we can say that we heard it here first, the School of Public Health, and you've created one, and you've put a shout out to others in the audience. So you heard it here first.
Sorry to put you on the spot, Aura.
So, Dr. Wisdom, you have been a public health leader in these communities for decades. You're also a ER doc. In the past, you were our state Surgeon General. I've had the pleasure of working with you for at least a minute of those decades. So from that perspective, what do you think are the most significant barriers we have to improving health outcomes, and what role do health systems play in transformation of population?
Great, thank you.
Yeah.
Well, I think one of the most significant barriers that we see in healthcare is not looking at the full continuum of health. Many of you have probably heard the quote that health occurs where we live, learn, work, play, and pray. So while at Henry Ford Health System, of course, and other systems, we want to provide the highest quality of care, absolutely. But we also have to realize that you can provide that great quality of care, but if we don't look at those other social determinants, it just doesn't make that high quality care as effective. So when I say social determinants, we mean addressing housing instability, and food insecurity, and transportation, and education. Those are key if we're truly going to have major health outcomes. So when we look at that, Dr. McGinnis came out with a study probably around 2002 that said that about 10, maybe 20% of our health is due to health care, but we have to address those other aspects such as lifestyle, and that's where American Heart Association and public health are very key, because you can provide the absolutely best quality health care, but if you don't address those social determinants, we're not going to realize the most favorable outcomes. I think one other thing that's important in terms of barriers is that we have to realize, you mentioned about eliminating heart disease, and I remember nationally, Healthy People 2020, 2010, it was first about, in terms of the health disparities world, it was about reducing health disparities. And then we sort of moved with Dr. Satcher's leadership under eliminating health disparities. So I think it's going to be very important in terms of a barrier is to address inequities and unplanned inequities, because many of the inequities that we see have been planned. So we have to be deliberate, intentional in terms of unplanning these inequities that we see in our communities if we're truly going to eliminate health disparities and achieve health and healthcare equity. And I think another barrier is perhaps not being urgent enough and aggressive enough and innovative enough. Henry Ford Health System, of course, we think certainly that innovation is in our DNA, based on our founder, Henry Ford himself, and putting the world on wheels. However, we need to really keep that innovative spirit in terms of what we do. So one of the very innovative things that we've been involved in terms of infant mortality, and you sort of heard that theme several times during this presentation, is that we have found innovative ways to address infant death through working with the mayor's office, our public health department. But at Henry Ford, we've developed a women-inspired neighborhood network Detroit, or called WIN Network Detroit, where in our first cohort we saw out of 323 women, 0 preventable deaths among very, very vulnerable and underserved women. And now we have another model that is called Centering Pregnancy, where we combine a community health worker co-facilitating the sessions with a certified nurse midwife, and again, nearly 100% breastfeeding, near 0 infant deaths. So we're really seeing transformation occur, and we know those same principles can be applied in terms of heart disease prevention and having a more comprehensive approach in terms of what we do.
Exciting. And I heard you mention several times throughout innovation. And that's going to be the key, right? I think that kind of goes back to one of the previous comments about, you know, we look at what's working, we stop doing what's not working, and we don't do it just because we've always done it, right? But to look at how we should be doing it going forward. That's an important piece.
Thank you.
So while I'm looking towards you, one of our questions, Dr. Wisdom, is for you. Okay. So I'll stay right there and say, is there a way that Medicaid or the health systems can fund nonprofits working on the social determinants of health?
Boy, well, I certainly can't answer from the Medicaid standpoint. That's a little bit, when I was Surgeon General, that's a little bit out of my purview at this point. But in terms of how agencies, social service agencies can address social determinants of health and how we can work together. For one, every health systems that are nonprofit have an expectation to complete a community health needs assessment and then develop an implementation plan to address these social determinants. And that's in order for us to maintain our 501c3 tax-exempt status. So there are ways that collaborating with nonprofits, we can actually work together to address those social determinants. At times it may be collaborating in terms of resources, human resources, but at times identifying funding resources that we can apply to that setting and work with those nonprofits as well. So I think that's where that innovation comes in, and we work with multiple entities. We have at Henry Ford Health System 200 community-based partners, and some of those partners we've actually written grants together with and received funding in order to help them fulfill their mission also. But times kind of leveraging the human resource can be invaluable in terms of addressing those social determinants of health.
Absolutely. So it sounds like even though health systems may not directly fund not-for-profits, if they go in grant seeking with a strong partner like a health center, that may actually help to loosen up that money and have it.
And we write a lot of letters of support for entities so that if they see that they're partnering with an anchor organization, a university, a health system, public health, having us write those letters of support and working collaboratively, it gives those nonprofits a greater chance of being funded, and then it strengthens our ability to work together to achieve the outcomes in terms of our community health impact.
Great. Ms. Black, what is the role of the calcium coronary scan or score in identifying high risk for heart disease? And is this score better than the cholesterol blood test? And if that's not truly a question for you, we have two docs on the on the stage, and I see a few docs in the audience. So.
In the interest, I am not a cardiologist, nor do I play one on TV. So, so I would defer that question to those who may have a little bit more advanced medical expertise on that front, or we will follow up. But
okay, so that was the calcium coronary scan, that score in identifying heart disease. And is that better than the cholesterol blood test?
Yes. So, okay, I do practice emergency medicine. I'm not a cardiologist. So, I will say I think the most recent evidence has been showing there's some promise in that score. From an emergency medicine standpoint, I don't look at that score. I look at someone who's in front of me clutching their chest, and think, do they have a heart attack or not? So that is what I'll say to that question.
All right.
I have no idea. I'm just an ophthalmologist.
That's important. That's important.
I think we have officially answered that question. All right. Dr. Calhoun, I'll move back to you. So by improving health outcomes in Detroit, does that have implications for vulnerable populations in other parts of our state, especially like in rural areas and such?
Oh, absolutely. I think driving health outcomes in Detroit absolutely will have an impact on health outcomes across the rest of the state. And I was speaking earlier this morning actually about how the difference between Baltimore and Detroit. And I said earlier, Baltimore has a similar population, right, as Detroit. But when you think about Detroit, it's vastly spread out, right? 139 roughly square miles. And there's not, we all know this, you've been in conversations over the past few days, there's not a robust transportation system in Detroit. So when we think about how you provide services and impact public health in Detroit, it's almost like you're thinking urban, but with a rural, in a rural way, right? So a lot of the work we're doing now is bringing programs and services into the community, trying to build on the assets of those neighborhoods and the community. One example of that actually is a program, I'm glad you both mentioned it, it's a program called Sister Friends, right? And so we already knew the mayor had supported and had really helped build Make Your Date years ago, an infant mortality preterm birth program. So what we said was, okay, we've got that strong program. How can we build this hospital and public health collaboration? So now, in addition to Make Your Date, we've actually built on mentors that are based in these neighborhoods, in these communities. We actually have partnered with Lyft, so actually providing women rides to their Make Your Date appointments, and really just getting into those neighborhoods. So I think as we think about public health in Detroit, a lot of it can actually be applied to how we think about rural areas as well and getting into the neighborhoods.
Absolutely. Ms. Black, I'm going to go back to you again. And I think this is truly a question for you this time. So has the American Heart Association looked at the impact of social determinants of health on cardiovascular disease? And you're nodding your head, yes. So what have you found?
Yeah, absolutely. There's actually a whole policy paper on this very topic, exactly because the Heart Association, we're very scientifically based and everything sort of based in research, and we set very robust goals. And so in 2010, we set the goal that we were going to reduce cardiovascular deaths from cardiovascular disease and improve cardiovascular health by 20% by 2020. That was the goal. And as we've assessed progress along the way, the deaths have declined dramatically, but if you look at the improvement in health, and particularly if you disaggregate the data, there's tremendous disparities around where we've seen improvement and where we haven't seen improvement in cardiovascular health. And in diving into that, it really inspired people in a way to kind of look beyond what was happening in healthcare specifically into the broader context of what was going on. And absolutely, we found a significant connection between people's access to care, their access to healthy food, their access to transportation, housing security, poverty, safety. All of these other factors play a tremendous role in people's cardiovascular health. And so we can't genuinely improve the cardiovascular health of all Americans and eliminate health disparities and achieve health equity unless we are genuinely addressing those social determinants, those other influencers in people's lives.
For sure. I'm going to head down to the other end of the panel now, and I'm going to start with President Wilson, and then I'm going to ask a similar question of you, Dr. Wisdom. So, President Wilson, what should the role of academic institutions be on the public health in Detroit, and then what should the role of large health systems be? So, President Wilson, let's start with you. The role of academic institutions, and then the role of large health systems in the public health in Detroit.
Yeah, as I mentioned, because health disparities is such a complex interaction of so many different factors, not all related to genetic and biological factors, but also social factors, environmental factors, behavioral factors. I think one of the things that academic institutions can bring to bear are the resources in terms of people who have these other perspectives and other approaches that's outside of the traditional healthcare delivery model. Mm-hmm. One of the things that has hit home to me personally when I was at the NIH is located in Bethesda, Maryland, which is right outside Northwest DC. And I grew up in Southeast DC on the other side by the Anacostia River. They used to call us the River Rats. Anyway, there was a statistics that I found at the time that I was working at NIH, which was that there's a for a black male, there's a 19-year difference in mortality if you live in Southeast DC or Northwest DC. And having grown up in Southeast DC and now living right outside Northwest DC, that really struck home. And it turns out that it's 19 miles between the border of Southeast DC and the border of Northwest DC. So that means that for every mile that you go from the edge of Southeast DC to Northwest, you gain a year of life. Mm-hmm. I mean, that is really just unbelievably poignant. And then as someone who's experienced both, I really had to pay attention to that.
Mm-hmm. Absolutely.
Yeah.
Dr. Wisdom?
As healthcare systems and universities, we're anchors in the community. So it's very important for us to, in that anchor role, meaning that we're going to be there. We've been there for a long time, Henry Ford, 102 years. I believe Wayne State, probably close to 100 years or
150.
150, okay, beyond 100 years. The role of our anchor organizations is to come together in ways, because the likelihood that we'll be in a space for a long time to come is very important. So I think our role as anchors and taking that responsibility in terms of looking at alignment, looking at metrics, as Dr. Khaldun said, looking at the collective impact and finding out how collectively we can look at the impact that we're making in our communities, I think is a very key role. Also, the element of providing access, and when I say access to care, of course, clinical care, but also other types of care. So access can occur through using technology, telemetry, that sort of thing is a major role that health systems can play. The understanding and serving the community, understanding the community well, when particularly around health disparities and equity. And let me just pause for a minute to describe a picture to people, because people think equity and equality, they're synonymous terms, it all means the same thing, and I don't quite understand that. We treat everybody equally, everybody fairly, that sort of thing. When we think, just imagine three children wanting to see a baseball game, and there's a fence in front of them, and you see the baseball diamond. Well, the tallest child will be able to see over the fence and see the game, meaning that they'll realize their fullest health potential. The middle child, a little shorter, will not be able to see the game, and of course the smallest, shortest child won't be able to see the game at all, has no hope. So if you talk about equality, you give all of them a crate. The tallest person can see better, the middle height person can see a little better, the shortest person can maybe not quite see. So equality is a nice thing, but it's not enough. When we talk about equity, what we really talk about is having the input or the crate that truly allows each student to fully see the game, or each person to fully realize their fullest potential, health-wise, career-wise. So the tallest person doesn't need a crate at all. The middle person may need one crate, the shortest person may need two in order to fully see over that fence and realize full health potential. So when we talk about what health systems can do and what is to truly understand what inputs are needed in order for individuals to not only realize their greatest health, optimize their greatest health potential, but also their greatest life potential in terms of contributing. So I think that's a huge role, understanding that, conveying that message, but also operationalizing that message by providing food to people that may have food insecurity. We're looking at how to connect health and housing and where that intersects. So there are many opportunities for anchor organizations to come together and truly see a more equitable society and a society that leads to more opportunity as opposed to otherwise.
I thought of one other thing. I probably should have mentioned it earlier in terms of the role of an academic center, a university. I think it was 2 years ago now, we started a major in public health. So that our students can, besides the traditional majors that students go into, there's actually a major in public health they can do now, where they can get a bachelor's degree and have some expertise in the public health, population health sphere. That means that, and by the way, it's becoming one of our most popular majors. It's almost overtaking psychology as the most popular major. So that means that year after year you have a cohort of trained people who are going out into the workforce who have that mindset of population health. And I think that over time, that makes a big difference.
Yeah. Absolutely does.
I just wanted to add in the spirit of partnership. One thing I started at Johns Hopkins University when I was in the Baltimore Health Department was actually a collaboration between the health systems, between the academic university, and had the residents and medical students actually coming through the health department as part of their rotations. So I'll raise my hand and say, I'm excited about School of Public Health.
That's
Actually,
good.
I already have some Wayne State students actually coming through the health department now, so that's an opportunity for partnership.
And there's a quote that says, if you want to go fast, go alone. If you want to go far, go together. So collaborating together can help us go far for the long term as opposed to getting to someplace fast and more short term.
You know, that couldn't be a better lead in to what I believe will have to be the final question, and I'm going to throw it out to all of you. So you've all talked about collaboration, many hands, connectability, understanding that the clinical environment is only one piece, and it's a small piece in overall health. So who will or should lead this type of collaboration? And let's just take it right into Detroit. Who's going to lead this type of collaboration and make it a real collaboration with real outcomes and real impact? Who should be the leader of this?
Well, I'll start as the person who doesn't live in Detroit. I'll start by saying, not me, no, just kidding. That, there's another quote that is, imagine how much success we could have, and I'm not saying it correctly, if nobody cared who got credit, right? That I think as we go into an initiative like this, the key is not necessarily to think about who's the center. In fact, in really genuine collective impact work, the anchor organization often is kind of behind the curtain. That it's really about orchestrating, all the different players coming together in harmony, so that work is really synergistic. And then collectively, they sort of own the progress together. And so I think the key is leveraging the assets and the strengths of the organizations that are committed and interested, including all of us and perhaps many of you, and identifying where are those strengths and where can they best be leveraged, as opposed to thinking about sort of the centerpiece. Because I think in doing that, it necessarily sometimes creates a turfiness that can actually be an obstacle to progress.
Absolutely. Who else?
So Karen DeSalvo, as many of you may know, was a national HHS director, talked about this concept of public health 3.0. And it really is about moving away from a local, state, whatever is your public health leader, being the place where they just kind of provide these individual services and think kind of siloed about the local health department. So I think there's a real opportunity for local public health to be one of the leaders when we talk about these disparities and equity. And absolutely, the way Baltimore actually was able to address those various things, there's something called Be More for Healthy Babies. It's not the Baltimore Health Department has this particular program. They brought together over 100 partners. The health department was behind the scenes, right? They got many partners. They were able to kind of show this accountability and really drive things forward. But it was a partnership. And actually, the health department was one of 100 different logos that is on the Be More for Healthy Babies website. And so I think that's, to your point, we really have to get away from individual organizations winning, right? We win when the people are healthy, right? And that is the main goal. So I think the local health department can play a strong role in that.
President?
I really can't add to what's already been said. I think everyone has a role, and no one individual, no one organization has a more important role than another.
Right. And I think co-leadership is key. And the reason why I say that is because there needs to be some level of accountability. Who do you go to in terms of how those metrics, because I think, and we saw David Hefner talked about that accountability piece. I think in our state and our country, one thing that's missing is oftentimes who's responsible if the infant mortality rate doesn't go down? Who's responsible if the childhood obesity rate goes up? Who's responsible? And I've been asking that question for a long time. So in terms of leadership, it's not so much about credit and that sort of thing, because actually Henry Ford has worked with DMC St. John Providence and Legacy Oakwood around our infant mortality work. 3 competing health systems came together, and we've accrued almost $4 million in grant funds over that time. And many times Henry Ford has taken that back seat. We have not been the one to get all the credit. We've not been the one on the newspaper article. But I think in terms of accountability, there needs to be co-leadership and 2 or 3 entities that are responsible and accountable. So you look to them when the data's great, you say wonderful, you know, but if the data doesn't really achieve the outcomes that we want, then, and I see the lights blinking, then we know that we need to do better. So from an accountability standpoint, I think there needs to be some co-leadership.
Thank you so much. And I think the final word is we all win when the community gets healthier.
Exactly.
Thank you so much. Thank you.